So most of the after a good panel discussion on the EGFR mutation and most of the slides covered by my colleagues and seniors. So I just try to summarize the management of the EGFR mutated non-small cell lung cancer. We all know the worldwide is the most common cancer in the lung and the most common cause of death in the all sexes, both sexes and all ages is the lung cancer only. So yes, what is the first line option we have? This we have actually for the EGFR mutation. I am talking about the only the common mutation is the exon 19 deletion and L858R mutation. So yes, we have an option of first generation, second and third generation TKIs. Third generation TKI right now is the most common TKI. We use osimertinib for our patients. Those patients who detect with the exon 19 deletion and L858R. So our first line treatment is the osimertinib. And you can see EGFR mutation discovered during first line systemic therapy. Yes, we can interrupt the treatment. We can complete our chemotherapy as we have planned, and we can shift when a patient progression at the physician choice only. So yes, answer is the osimertinib for the all EGFR sensitive mutations. So yes, the patient, those who diagnosed with the same, the strong recommendation by the all panel, all guidelines by the osimertinib monotherapy. Yes, the moderate, moderate recommendation is the gefitinib with doublet chemotherapy. This is most used in the data. So mainly this is a data trial actually. Documentary monotherapy with the afatinib, allo bevacizumab, allo ramucirumab, and the first generation and rest second generation TKI we can use, but the most common use is EGFR. So there is some basic pharmacokinetics difference with the drugs. You can see in this charts. EGFR sensitive mutation inverse activity for the first generation. You can see in the second generation they have some rare mutations work also, and in the third generation there is sensitive mutations inhibitors as well as T790M mutation inhibitor also. The reversibility, yes, first is a reversible, second is a irreversible binding, third one is a irreversible binding. Targeting reversible binding of the EGFR ATP binding site. For the second generation, they are the covalent modification with the ATP binding site or the EGFR cis and HER2 cis site. For the third generation, there is a covalent modification of the ATP bindings of the EGFR cis mutation. Yes, able to do cross blood-brain barrier. First is very minimum, second is minimum, and third is significant. And in the first generation is EGFR is gefitinib and second is afatinib, third is the osimertinib. This is a monoallelino pyrimidine sense. So you can clearly see they work on a 19 deletion and L85821 and as well as the T790. Inhibition of T790, lower activity against the wild type, but crosses the blood-brain barrier is the preclinical as well as the human studies. So first trial that is published in the metastatic setting, this is a FLORA phase 3 trial. They randomized first generation Jef-Arlo versus osimertinib, quite well missed inclusion criteria, and stratification done with the basis of the exon 19 deletion and 21 deletion as well as races. Crossover allowed. Primary endpoint by the PFS, secondary endpoint by the OS, as well as subset analysis with the response, duration of response, safety analysis. The PFS, you can clearly see there's a good PFS benefits, 18 versus 10 month, good hazard ratio 0.46 and significant p-value. And this is powered for the PFS only. And you can see in the subgroup analysis, excellent forest plots favor the osimertinib with the excellent hazard ratio in all subgroups. You can see the OS analysis. You can clearly see good median OS survival. You can see the 2-year survival 60 versus 74% in the osimertinib. Median OS is more than 3 years. Osimertinib patient will more likely to be alive at second and third year. This is the landmark part for this trial. First time an EGFR TKI translate PFS into the OS. This is the first TKI that translate PFS to OS. Safety analysis, you can see. This is the part where the 28% of patient is still received 3-year osimertinib compared to the comparator arm. There is only 9% patient received that other treatment, and 22% and 5 in the osimertinib arm patient received treatment after the data cutoff, and 5% in the second arm. So you can see there is a more chances of subsequent therapy in the osimertinib. And this is the time to first subsequent treatment. You can clearly see osimertinib has a good value. There is an event is quite good. So yes, osimertinib patients have received subsequent treatment is later, but compared to the other TKI. So yes, this is the first line. Gefitinib PFS around 1 year. You can see erlotinib around 13 months, afatinib around 11 months, and 19 months is around osimertinib with the FLORA trial. And yes, PFS and OS is supplement in the all subgroups. You can clearly see in the forest with the good hazard ratio. Yes, that OS benefit in subgroups as well as intention population favor the osmotive compared to other TKI. Then right now, just little bit about Indian data about the first line TKI with the 1 year PFS around 6 to 8 months, OS around 18 months or 20 months in the all TKIs. So there is some studies that is compared some decomatinib versus osimertinib is the newest one is the TKI. You can clearly see decomatinib versus gefitinib in the ARCA trial versus FLORA. You can see this trial is primary endpoint is the PFS in the both, but overall response rate is the decomatinib study. They powered a secondary endpoint as the overall response rate compared to OS is the secondary endpoint in the FLORA study. They only included patient with the recurrent or non-small cell lung cancers. They are included locally advanced as well as metastatic lung cancers. The exclusion criteria you can clearly see there is in ARCA trial, they didn't include leptomeningeal or brain mets patient, but in the FLORA trial, yes, they include the CNS metastasis patient, those who are stable and those who are not required steroids. So they are a good separation of the curve in the FLORA, start to end. You can see there is a 6 month, there is no separation between the ARCA and trial. Ashok ji, मैं class ले रहा हूँ, वापस call करता हूँ. So yes, there is a good separation of the curve in the FLORA compared to the ARCHER. There is a 6 month separation after the 6 month. So yes, one more part is very important for the regarding ARCA because ARCA is designed for the statistical significance with the response rate. But yes, in a response rate, you cannot statistically significant the OS on the basis on the response rate only. But thus again compared to FLORA, FLORA is directed to the PFS only. Yes, and significant PFS translate to the comparable OFS. There's a content analysis of the ARCA trial, and this trial, trial, they written as a beautiful line. The trial had a hierarchical stratified statistical design, and given that it did not meet the significance in the overall response rate, so a p-value could not given to the OS. And when compared, this is an open label study compared osimertinib is a double blinded study. They include the brain mets and leptomeningeal mets patient. Yes, osimertinib included. Median PFS is good. Separation is quite good. Response rate is good. Median duration of response, median OS is good. And dose reduction and serious adverse events is quite safety is main part of the osimertinib compared to the decomatinib. There is a complete dose reductions, and this treatment discontinuation is more with the decomatinib. When we talk about the lung, afatinib and ARCHER, yes, afatinib failed to improve OS versus gefitinib in the lung, and same about the ARCHER. They are designed for the ORR, but OS you cannot, basis on the ORR, you cannot say it's a OS benefit. So you can say stable brain met patient includes 16% in the lung. There is no brain met patient in the ARCHER. There is stable brain met patient around 19% in the FLORA, and there is a PFS benefits you can clearly the best in the FLORA trial. And now we talk about the CNS. The CNS penetration with the first generation TKI is very poor compared to the second or third. The third generation TKI has a good penetration, brain penetration. So first generation is poorly distribution in the brain, but the third generation, yes, osimertinib is a good blood-brain permeable, or this is actually proven in some clinicals and in some human study also compared to the other TKIs. So in and the other TKIs, they didn't include the patient, and as well as they didn't subset analysis of CNS metastatic patient. But in the FLORA trial, you can say both systematic as well as intracranial efficacy were analyzed, and osimertinib shows superior efficacy to compared to the erlotinib and gefitinib. Efficacy patient with the brain mets was not investigated in the erlotinib and gefitinib. And lung 3 or 6 studies evident no significant improvement in the systemic response compared to the chemotherapy, and neither study assessed the intracranial response. Yes, so osimertinib is the only TKI that report intracranial efficacy. And you can see the patient with the CNS mets, the median PFS around 15 months, and in those who are not CNS mets, is a median PFS around 19 months. So yes, hazard ratio more or less similar. You can say there is a no significant PFS different also in the patient, those who have a CNS disease or those who not CNS disease. But yes, CNS benefit also in this trial. And intracranial CNS benefit, you can see there's a clear intracranial CNS benefit with the osimertinib compared to the other comparator TKIs. And yes, PD on the osimertinib is around only 19% compared to the other TKI. There's around 40% progress on the TKI. Or that is a parts, yes. So if a patient with the brain mets, you can start with the osimertinib. Leptomeningeal spinal mets, yes, our choice is osimertinib only. Tolerability profile, there is a very good tolerability with the osimertinib. Only 15% patient is discontinued for treatment or any adverse event. Grade 3 event is around 18%. This is quite comparable with the other TKI. This is more adverse event with the first generation TKI. And you can see clearly around diarrhea, rashes, and other side effect is around 1 to 2 or 1 to 3%. This is almost comparable with the first generation TKI. This is less or similarly same with the first generation. So in the Lux Lung trial, you can patient is a dose reduction is more frequent compared to afatinib and gefritinib. In Archer, there is around 66% dose reductions, 41% in the Lux Lung, but only 4% in the Flora. So yes, this is a most tolerable TKI. And when compared to both Archer and Flora, you can see around 66% discontinuation in the Archer and only 2.9% discontinuation in Flora for any serious adverse event. And when you about the use of the analysis of the Archer in the geriatric population, higher incidence of grade 3 and grade 4, most frequent dose interruptions, most frequent discontinuations. So this is a synopsis for the patient. Osimertinib, we thought around 19-month PFS, and after that, all patient receives chemotherapy or any other treatment. But when we talk about the first generation TKI, 1/3 patient received a patient validated for the T790M, and 1/3 patient received TKIs, and 1/3 patient receives a chemotherapy, and 1/3 patient doesn't receive any kind of therapy. So this is the most important, right? Whenever you place a patient on osimertinib, yes, subsequently you can easily plan for another treatment. But when you are start with the first generation TKI, this is difficult to plan for any subsequent therapy because of their loss of their performance status, as well as their progression-free survival is low. So this is analysis and some you can clearly see patient start with the first generation, around 17% patient receive second line, and in that around 60% validated receiver T790M test, only 50% as a valid T790M, and only 2 or 3 patient able to receive is a second line osimertinib. So only 1/3 patient receive osimertinib in this studies. And one more most important studies, that is starting with the prior generation TKI like afatinib. They start with the afatinib in the geotech study, followed by the osimertinib. So this study will be quite good median OS. You can clearly see it's 14-month one. So geotech study suggested reversing osimertinib for the second line after failure of TKI may result in the better OS. But the median OS for the patient who receive afatinib followed by osimertinib is around 40 months. It's a quite good OS, but this is already have some flaws in the studies. First one is geotech is a retrospective analysis study. They exclude patient T790 negative or not tested. Died on those patient is not included. Those of on a first line afatinib. Geotech endpoints in TTF cannot be compared with the PFS and included treatments beyond the disease progression. OS was the extrapolatory points. Geotech patient had a higher incidence of deletion 19.7 exon mutation. Must have initial osimertinib more than 10 months before the enrollment. Shorter treatment duration were excluded. It is not possible to draw conclusion about a relative benefit of the subsequent sequential afatinib osimertinib versus first line on osimertinib without head-to-head comparison. You have to head-to-head comparison. Otherwise, on a basis of the retrospective analysis, you cannot say this study had a highest OS. Sequencing about the prior generation TKI followed by the when patient develop EGFR T790 mutation, then you have shift to osimertinib. This is not a good approach because you cannot figure out which patient going to be develop EGFR T790. Not everyone will be well enough to receive additional treatment. Tissue or liquid biopsy not always successful. Osimertinib associated with the good survival benefits. This is the real world data. This is a flower data. You can see this is an Italian study. You can clearly see 18-month PFS and as well as the good OS in these patients. And in the real world, there is a safety analysis. You can see it's almost similar to the trial, but yes, thromboembolism were more frequent in real world compared to the that published in the study. And this is the Aussie factor study also. This is one real world setting analysis. Median PFS around 20 months, median TTF around 19 months, and you can see the duration of response, overall response, all are good with the real world analysis. So yes, and Aussie fact analysis, the pneumonitis of all grade was higher compared to the flow trial. So in the real world, there yes, pneumonitis, thromboembolic incidence are quite is higher compared to the flora. Otherwise, all our survival is same. So same with the Mykonos study. So this is the 3 good real world study with the osimertinib, and long-term outcomes will be evaluated with the, all this study. Yes. So overall, osimertinib is the drug of choice for the EGFR exon 19 deletion and other EGFR mutation patients. Is a good OS, easily tolerable, less discontinuation rates, and the safety profile is quite good. Quality of life patient is maintained. So yes, my choice is osimertinib for the all patient. Now we talk about the FLORA-2 trial. This is a quite still debatable trial. Most of clinicians are using this trial with the because the 2-year survival, 2-year PFS around 41% in the osimertinib arm compared to the 57% in the Osi plus chemotherapy arm. Median PFS around 25 versus 16 months. So yes, we can use the that data also FLORA-2. But toxicity is grade 3, grade 4, especially hematotoxicity, sub AKI as well as GI toxicity is quite high in the FLORA-2 approach. So whenever your patient is young, fit, without any comorbidities, performance is good at the presentation, yes, you can go ahead with the FLORA-2 approach. Otherwise, the FLORA is the best answer for the EGFR mutations. Thank you.